Good morning, everyone. It's a pleasure to be here today and start this web seminar, COVID-19 and pregnancy. First, I would like to thank you for the support by Astraia, and I would like to thank you again, Giancarlo Di Renzo, that is always open for these new things and to bring new informations. Today, uh, next slide, please. Can you move for the next one? Yeah, please. Uh, please, I would like to show the program flow. Fabio, show me us the program flow. It's one before. Okay, today we are going to divide our seminars in the introduction, where I can tell you about the speakers, and then we are going to have the FIGO and ISUOG guidelines by Liona, Poon, and Anil, Kapur. And later on, Giancarlo Di Renzo is going to tell us what you should tell patients and how to organize an obstetrician service to support patients with COVID. And then later on, I'm going to bring some situations in Brazil and some initiatives. So next slide, please. Next, Fabio. Okay, I'd like to thank you first, Liona Poon. She is professor of Department of Obstetrician and Gynecology for the Chinese University of Hong Kong. Professor Anil Kapur, vice chairman of the World Diabetes Foundations and member of the FIGO NCD committee with Moshe Hod. And Giancarlo Di Renzo, that is professor and chairman of the Department of OBGYN, director the Center of Perinatal and Reproductive Medicine in the University of Perugia. Let's start by Liona with the FIGO guidelines and ISUOG guidelines. Liona, please.
Thank you, Eduardo, and good evening, good afternoon, good morning, everybody. So I have two tasks today. One is to cover the FIGO guidelines, and then I will cover a little bit about what you need to do in relation to obstetric ultrasound based on the ISUOG guideline. So in relation to COVID-19 and pregnancy, to date, it seems that clinical characteristics of patients with COVID-19 infection are similar to those of non-pregnant adults. Currently, there is no evidence that pregnant women are more susceptible to COVID-19 infection. However, we know that in non-pregnant patients, when they have comorbidities such as diabetes, they are at a higher risk of adverse outcomes as a result of COVID-19 infection, and perhaps Anil can elaborate more on that later on. And coming back to pregnant women, severe morbidity and mortality are not evident in pregnant women with COVID-19. And obviously, we're all very nervous about vertical transmission, but it seems that the information is limited and there is no evidence to date. Ongoing collection of clinical data and research is underway with the aim of answering questions in relation to perinatal risks and the optimal intrapartum management and timing and mode of delivery. So when it comes to management of women with COVID-19 infection, we believe the place of care is extremely important. And Professor Di Renzo will cover more about how you should prepare your unit for that. But these are some rules that we believe you should follow. Pregnant women with confirmed COVID-19 infection should be managed by a designated tertiary hospital so that you can centralize care. Suspected or probable cases should be treated in isolation, and confirmed cases should be managed in a negative pressure isolation room although it is recognized that these may be unavailable in many units. A woman with confirmed infection who is critically ill should be admitted to a negative pressure isolation room in the ICU. Ideally, negative pressure isolation rooms should be set up for safe labor and delivery, as well as for neonatal care. All attending medical staff should don PPE. That includes fit tested respirator, goggle, face protective shield, water-resistant surgical gown, and gloves when providing care for suspected, probable, or confirmed cases of COVID-19 infection. In areas with widespread local transmission of the disease, healthcare services in both high and low income countries may be unable to provide such levels of care. Pregnant women with a mild clinical presentation may not initially require hospital admission, and home confinement can be considered. If negative pressure isolation rooms are not available, patients should be isolated in single rooms or grouped together once COVID-19 infection has been confirmed. With regard to antenatal care, here are our recommendations. Several precautions should be taken to minimize the risk of transmission between pregnant women, healthcare providers, and other patients in the hospital. The number of clinical visits in low-risk women with uncomplicated pregnancy can be decreased and replaced by virtual visits using phone or video calls. Women may be advised to check their blood pressure at home if possible, with appropriate advice given when to seek medical assistance. It is useful to contact women prior to clinic visit to request them to arrive without a companion, as well as to screen them for symptoms or exposure relevant to COVID-19. In cases of positive screen, the visit should be deferred by 14 days unless the visit is urgent for maternal and or fetal reasons, in which case the healthcare providers should be made aware and they should use proper PPE. It is also advised that all patients undergoing screening should undergo screening at the entrance to the clinic or medical center. In case of screen positive, the patient should be asked to wear a mask. She should be evaluated for the presence and severity of symptoms and tested for COVID-19 and based on local protocols. Although there is currently no evidence that COVID-19 infection is associated with fetal or placental complications, until more data become available, we advise closer fetal monitoring with monthly ultrasound for fetal growth, amniotic fluid, and fetal anatomy. A detailed morphology scan at 18 to 23 weeks of pregnancy is indicated. When it comes to obstetric triage, here are our recommendations. As per antenatal care, you should provide the same screening for COVID-19 symptoms and or risk factors. Women with mild symptoms with no risk factors for severe disease may be discharged home after being advised to monitor symptoms and to seek care in case the symptoms worsen. Women with moderate disease or those who have comorbidities or with other risk factors for severe COVID-19 should undergo detailed assessment, including physical examination, laboratory testing, and chest radiography as indicated. Decision regarding further management should be individualized based on symptoms, risk factors, and the results of the assessment. And of course, women with severe symptoms should undergo detailed assessment by a multidisciplinary team for supportive management. In relation to intrapartum care, we recommend that COVID-19 infection itself is not an indication for delivery unless there is a need to improve maternal oxygenation. Timing and mode of delivery should be individualized, dependent mainly on the clinical status of the patient, gestational age, and fetal condition. Vaginal delivery is not contraindicated in suspected, probable, or confirmed COVID-19 patients, but shortening the second stage by operative vaginal delivery can be considered, as active pushing while wearing a surgical mask may be difficult for the woman to achieve. There should be a low threshold to expedite the delivery when there is fetal distress, poor progress in labor, and or deterioration in maternal condition. Septic shock, acute organ failure, or fetal distress should prompt emergency cesarean delivery or termination if legal before fetal viability. For the protection of the medical team, we do not recommend water birth, given the evidence of virus in feces and the inability to use adequate protection equipment for healthcare workers during water birth. Both regional anesthesia and general anesthesia can be considered depending on the clinical condition of the patient and after consultation with the obstetric anesthetist in accordance with recommendations of obstetric anesthesia societies. But we know that regional anesthesia is preferred because general anesthesia is considered an aerosol generating procedure, that should be considered first. For preterm cases requiring delivery, we urge caution regarding the use of antenatal steroids for fetal lung maturation in a critically ill patient. The use of antenatal steroids should be considered in discussion with infectious disease specialists, MFM subspecialists, and neonatologists. In the case of an infected woman presenting with spontaneous preterm labor, tranquilizers should not be used in an attempt to delay delivery in order to administer antenatal steroids. With regard to postpartum and neonatal management, at present, limited data suggests that there is no evidence of vertical mother-to-baby transmission in women who develop COVID-19 infection from mid-trimester of pregnancy, though recently there have been several reports reporting the presence of IgM in neonatal blood. However, the serological picture is not in keeping with an active infection, and therefore we call for high quality of data to confirm such finding of vertical transmission. For suspected probable confirmed cases of maternal COVID-19 infection, following delivery of the baby, we recommend that the umbilical cord should be clamped promptly and the neonate should be transferred to the resuscitation area for assessment by the attending pediatric team. There is currently insufficient evidence regarding the safety of breastfeeding and the need for mother or baby separation. But if the mother is severely or critically ill, separation appears the best option, with attempts to express breast milk in order to maintain milk production. There should be a dedicated breast pump, and after each pumping, the device should be thoroughly washed according to manufacturer's recommendations. If the patient is asymptomatic or mildly affected, breastfeeding and collocation, also called roaming in, can be considered by the mother in coordination with healthcare providers, or may be necessary if facility limitations prevent mother-baby separation. Since the main concern is that the virus may be transmitted by respiratory droplets rather than breast milk, breastfeeding mothers should ensure to wash their hands and wear a surgical mask before touching the baby. When roaming in, the baby's cot should be kept at least 2 meters or 6 feet from the mother's bed, and a physical barrier such as a curtain may be used. The majority of postpartum visits may be conducted remotely as long as the patient does not have specific concerns that require in-person examination. We also want to emphasize the need of psychological intervention because during pregnancy, if a woman is defined with suspected, probable, or confirmed COVID-19 infection, they are at an increased risk for anxiety and depression. And they may exhibit varying degrees of psychiatric symptoms that are detrimental to the maternal and fetal health. Mother-baby separation may impede early bonding as well as establishment of lactation. These factors will inevitably cause additional stress for mothers in the postpartum period. Healthcare providers should pay attention to a patient's mental health, including promptly assessing her sleep patterns and sources of anxiety, depression, and even suicidal ideation. A perinatal psychiatrist should be consulted when necessary. So I end my part of the FIGO talk, and perhaps we can take some questions and Anil can chip in.
So if I may add, this is Anil Kapur here. I haven't got a presentation. I just wanted to add a few things. We need to keep in mind that COVID is a highly stressful situation for women during pregnancy. And given the fact that 1 out of every 6th or 7th pregnancy has hyperglycemia in pregnancy, and 1 out of every 8 or 10 women have hypertension during pregnancy, we should not forget to screen women for these conditions. And if they are known, we must ensure that they are properly managed, in particular in terms of home monitoring of glucose, home monitoring of blood pressure, and assessing them for preterm preeclampsia, and in case required, appropriate prophylaxis with aspirin may be started. One point, in case women have hyperglycemia in pregnancy, it is very important that it might be difficult for these women to control their blood sugars on diet and oral medications, and therefore it might be much more important to shift them to insulin, because it is much easier to control blood glucose levels using insulin therapy. We must also remember that in women who actually have pneumonia and who are hospitalized with severe infection, it is critical that these women are also monitored on a regular basis for their blood glucose values, because presence of hyperglycemia is likely to add bacterial infections over on top of a viral pneumonia, and this might complicate issues uh, and lead to other problems. Similarly, presence of high blood pressure, which has not been addressed, could lead to preeclampsia and preterm deliveries. And therefore, I just wanted to point out that these two conditions in particular, hyperglycemia and hypertension, must be paid enough attention, and we should ensure that women are properly screened uh, to rule out the presence of these conditions, because during severe infection and in pregnancy, the chances that women may manifest hyperglycemia is quite high, and if it is not treated, can cause multiple problems. So I'd like to end with that, and perhaps we can take questions.
Or would you like me to continue with my ISUOG talk?
Yes, Liona, and perhaps there are a few questions that have popped up. Perhaps you could take those. There's one question that is saying that, are you suggesting corticosteroids for preterm labor in suspected COVID or POS cases?
I think at the moment, in relation to women needing preterm birth, or that they come in for with spontaneous preterm labor, we are saying caution with the use of corticosteroids. But then you need to consider each case individually and discuss with the MFM subspecialist, infectious disease specialist, and neonatologist to determine the benefit and balance the risk.
There's another question which is asking, how does hyperglycemic state contribute to bacterial infections? Basically, when there is hyperglycemia and in case of diabetes, the immune status of the individual is compromised. The ability of the T cells to destroy microorganisms is compromised, and in the presence of secretions in the lung and presence of hyperglycemia and compromised immune function will lead to superadded bacterial infections, and you could get a superadded bacterial pneumonia on it.
Perhaps I shall continue with my next talk, and then we can take more questions if that's okay with everybody. Okay, let me see. Oh, see. So because I saw questions in relation to ultrasound, so maybe the answer can be found in my talk. I mean, this talk is quite comprehensive, so I hope I can get it done in 10 minutes. And we're covering 3 aspects in relation to obstetric ultrasound. First of all, we believe that there's a need to consider prioritization, and in case that your colleagues fall ill, or that women with a suspected COVID-19 cannot come in for ultrasound scan, and therefore we have developed this consensus statement. So to guide you in relation to how you could prioritize. Essentially, the basic principles are medical resources should be spared and prioritized. Maximum care should be taken to avoid unnecessary exposure of medical personnel to potentially infected patients and vice versa. The risk of infection is particularly high during ultrasound investigation due to the impossibility to keep a protective distance between the woman and the caregiver. Much emphasis has been placed in protecting staff for caring for women in labor, for doing operations, but there isn't much in relation to doing obstetric ultrasound, and therefore we felt the need of this document. The number of visits should be reduced to the essential minimum, and women should be advised to attend with no accompanying person to avoid virus spread. At the first point of contact, when the woman comes into the hospital or clinic, we believe that there's a need for screening. They should be screened for temperature, any history of travel, occupation, contact, and cluster named TOCC should be asked before or on arrival at the ultrasound department. This system should be set up either near the entrance or at the reception. And there is a 3-tier system for guiding you as to whether you should proceed with the ultrasound during the pandemic. Tier 1 means elective non-urgent ultrasound. Tier 2 is urgent ultrasound, and Tier 3 is emergency ultrasound. Tier 1, obviously, you can see that constitute not low-risk patient requiring routine first or second trimester scan. In our document, we have 3 tables, but then in the interest of time, I'll refer you to the paper. What we're stating here is that if a patient has missed the first trimester ultrasound scan, then you should offer NIPT or serum screening, and then a detailed scan in 3 to 4 weeks time after quarantine, because she has missed her essential 12-week scan. Then you should then schedule morphology scan at 18 to 23 weeks. We have widened the gestational age gap because we need to allow flexibility for perhaps you need to bring the low-risk cases to early gestation and leaving the later gestation for the high-risk cases or those with COVID-19. And then if a patient has missed the second trimester scan, then you need to schedule after quarantine in 2 to 3 weeks. The Tier 2 urgent cases, maternal indications include preeclampsia, diabetes, cardiovascular disease, and so forth. Fetal indications include positive first trimester screen, prior IUFD, prior preterm birth, prior fetus with anomaly, prior fetal growth restriction, and multiple gestation, and those with COVID-19 who are quarantined or infected. Then you should schedule the scan in 2 to 3 weeks according to service availability and gestational age. And For Tier 3 emergency, maternal indications include vaginal bleeding or abdominal pain in any trimester, or severe preeclampsia, critical illness. Fetal indications include suspicion of TTTS or selective fetal growth restriction or TAPS, fetal arrhythmia, fetal anemia, fetal structural abnormality, and fetal growth restriction, or those with confirmed COVID-19 who are hospitalized. Then they should have an urgent, they should have an immediate ultrasound scan or as soon as possible. And here I provide you with an algorithm as to how you could manage a pregnant woman in need of ultrasound in the context of COVID-19 infection. First trimester pregnancy, and woman with bleeding and abdominal pain, then she needs to be scanned and follow up as indicated to ascertain viability and rule out ectopic pregnancy. In the event when there's no vaginal bleeding or abdominal pain, no risk factor for ectopic pregnancy, then you should conduct ultrasound scan as per our consensus statement according to tables 1 to 3. Then you should do the first trimester dating scan or screening if available, anatomy scan at 18 to 23 weeks. When there are no abnormalities, then no further scans are needed. But if there are abnormalities noted, or when there are maternal, fetal or other indications, then fetal growth scan should be done every 4 weekly, commencing at 28 weeks. And if normal, then growth scan at 28 and 32 weeks, followed by no further scans. In the event when there is a twin pregnancy, there's known fetal growth restriction, known fetal anomaly, or amniotic fluid abnormality, then you should continue ultrasound scan until delivery. Frequency would depend on indication and gestational age, and may be as frequent as every 1 to 2 weeks. Utilization of umbilical artery Doppler and middle cerebral artery Doppler should be individualized. So moving on, I've talked about the importance of ultrasound and how we can't not provide a service, and there's a limitation in terms of the distance from the patient. So we've decided that it's important to cover the issue of PPE and hazard mitigation in relation to COVID-19 for practitioners undertaking obstetric and gynecological ultrasound. The reason why we think this is a very important topic is because there's unique attributes that would increase the risk of transmission between patients and ultrasound operators and vice versa. I have already alluded to the fact that we cannot keep a safe distance from our patients, and the ultrasound room or enclosed area is typically very small. And ultrasound rooms often have restricted ventilation. The scan time may be between 10 to 60 minutes. That is considered a significant exposure. And we conduct invasive or transvaginal procedures, and then the women may be asked to inhale or exhale deeply and hold breath. That could be obviously potentially a problem. And therapeutic and interventional procedures may increase the risk of exposure to bodily fluids. There's a risk of patient coughing, sneezing, or exhaling heavily close in your face. The surfaces of the ultrasound machine, the keyboard, touch screen, and trackball are touched frequently. So in relation to PPE, we've divided the patients into 3 groups. The safest group is the symptomatic and TOCC negative patients. In these women, we recommend that you don't wear your own clothes still, and in your work environment, you wear dedicated work clothes. You observe hand hygiene. You wear a surgical face mask. There's no need for respirator, no need for isolation gown, and you can consider disposable gloves. No need for eye protection and hair cover. For the next 2 groups, asymptomatic and TOCC positive, or those with suspected, probable, or confirmed COVID-19, or where there is widespread community transmission, then yes, you should wear dedicated work clothes. You should observe hand hygiene. You should use appropriate respirator, test-fitted respirators, and you need to wear disposable, fluid-resistant, and impermeable protection gown. You need to double glove, wear eye protection, and hair cover. And in relation to the use of transvaginal ultrasound as well as invasive procedures, then you need to make sure you cover the transducer by using either the standard condom or commercially available transducer cover. And in those with suspected, probable, confirmed COVID-19 infection, or where there's widespread community transmission, you should also consider covering the cable. In relation to staff environment, we believe the last group should have a bedside scan rather than in a clinic. You need to minimize the number of staff in the room, and you should ensure that the most appropriate person undertakes the scan in the shortest period of time. The last topic is relating to how you should clean your equipment in the context of COVID-19. We know that in a laboratory environment, the SARS-CoV-2 virus lasts for many days, up to 96 days, as you can see on the diagram on the right. So the ultrasound room should be cleaned thoroughly each morning, and all contents should be wiped with a compatible low-level disinfectant. The number of transducers connected to the ultrasound machine should be reduced to a minimum. We recommend 1 transvaginal probe and 1 abdominal probe. And ultrasound transducers and cables should be cleaned every morning, and they should also be performed after each scan. In addition, we believe that the patient couch or bed should be wiped with a low-level disinfectant prior to replacing the disposable paper cover. The disposable paper cover should be removed with gloved hands and folded and disposed of immediately after each examination. Ensure that highly touched surfaces of the ultrasound machine are thoroughly cleaned after each examination. And at the end of each day, the soiled linen should be handled using 2 pairs of gloves and disposed of in the appropriate container without shaking the linen. The room and equipment should undergo terminal cleaning using a low-level disinfectant. And of course, hands should be washed for 20 seconds afterwards. And here I'll give you some examples as to what we call low-level disinfectant. and the steps you need to take for cleaning the probe and disinfecting the probe after its use in a COVID-19 case. And when you clean, you need to disconnect the transducer, remove the transducer cover, if applicable, and dispose of in clinical waste. You need to rinse the operative end of the transducer with running tap water, clean the transducer with a soft brush and non-abrasive detergent, rinse the transducer with tap water, clean the transducer cable with a low-level disinfectant wipe, and then dry with a cloth or towel. And in relation to this disinfection, there are two types. You've got the chemical wet disinfection, and in my setting, I have the opportunity to use Tristel, and you can use the others, wet disinfection, and that is available in your setting. Or you can consider automated high-level disinfection. In my setting, I have the opportunity to use Trofon, which is sonicated hydrogen peroxide mist. So this is the end of my talk. I will be happy to take any questions. So there, I think I've already answered the ultrasound protocol, and yep, I think we've covered the ultrasound components with the previous talk. I think there's a question in relation to thromboprophylaxis, and currently our recommendation is that for severe cases with risk factors for venous thromboembolism, then you should consider. And there's also possibility that you need to consider for outpatient management if a patient is in home isolation, especially those with risk factors.
With regard to thromboprophylaxis, I'd like to add that there have been studies from Italy which actually indicate there have been intravascular coagulation in the lung blood vessels, and that group recommends the use of low molecular weight heparin, but we need to have more evidence around that at the moment.
Great. I mean, there's a question in relation to any evidence of presence of virus in vaginal secretions. A couple of reports from China in a limited number of cases have reported that the virus is not present in vaginal secretions in COVID-19 patients. So there's a question with regard to universal tests, and I'm sure you've all seen the recent publication correspondence in the New England Journal of Medicine from Colombia, and they have reported that out of about 200 women attending for delivery, the screen positivity is around 15%, and of these 15%, near 90% of women were asymptomatic, suggesting that in places where there is widespread transmission, then it might be sensible to consider universal screening. But that is only applicable in countries with widespread transmission. But if anybody has anything else to add, feel free. I'm just scrolling down. What treatment do you propose with full-term neonates testing positive? I'm suspecting this relates to term pregnant women with COVID, and I have already mentioned that it is not an COVID-19 infection is not an indication for delivery. And but obviously at full term, from what I have learned from my Chinese colleagues, you've got nothing to wait for, and therefore they were more proactive in delivering term women with COVID-19 infection. But perhaps Professor Renzo would expand on that in his talk. Do you think, let me see, some questions are quite long. There's a question for me. In relation to high dose steroid to reduce cytokine. I think in the experience of my Chinese colleagues, they have indeed used high dose corticosteroids in the management of critically ill patient with COVID-19. I think, as I mentioned before, management of such cases require multidisciplinary approach, and therefore is really according to each case, and should be in discussion with intensivists and chest physicians, and etc., maternal fetal medicine specialists, and so forth. So I think is not a concrete rule for every single case. I don't know how you feel. Perhaps we could consider more questions for later, and we could hear from Professor Renzo. Is that okay, Anil? Unless you have questions that you want to immediately answer, because there are quite a lot, and I cannot talk and look at answers at questions at the same time.
I think it is important for us to realize that there can be quite a severe critical infection, and that would require multidisciplinary approach. It would require that comorbidities are looked at, and each one of them is dealt with in the most appropriate way. Corticosteroids may be used, but then corticosteroids will also cause certain other problems. And I think it is a decision that needs to be made right at that spot by the multidisciplinary team.
So we would like to hand over to Professor Renzo.
Yeah, thank you. Can you hear me? And can I share my slide? Do you see my slide? I hope that is possible because I try to share. So good morning, afternoon, evening, according to where you are. I'm dealing mostly with things that are related to what we know about the virus. A very nice definition at the moment is that the virus is a spiky ball of genetic material coated in fatty chemical called lipids, measure 8 billionths of a meter in diameter, and has brought a whole horde for health. And you can imagine such a small molecule. Now what is here was already enough for knowing to obstetrician, but what I try to focus now is about what we need is to develop our own protocols for management during pregnancy, delivery, and the puerperium, and to reorganize with specific pathways the maternity units. One of the most important tasks which every hospital should have, if the hospital is chosen as a hub of maternity hospital, because we cannot have every hospital which deal with a COVID positive patient, is to set up a local task force. And this local task force should be multidisciplinary, have regular meetings, discuss and share decision making. That has been suggested to have a so-called COVID advisor, which can be even an obstetrician, doesn't matter, someone which make at least the coordination, a obstetrician, infectivologist, anesthesiologist, neonatologist, midwife and or nurse according to the local user, and a local administrator, because we need, of course, to have a connection with administration for orders and for changing our, needs. What we need is to have a free kind of, let's say, control of patient. One is to set up a triage call center. This is a all pregnant women toll-free number in order to limit the unnecessary hospital admission. This has been a reinforcement of what Liona just said. Then we should have a mobile screening team for suspected infection to give advice to the patient before arriving in the hospital if it's needed, and then to organize the COVID area, okay, with a planned dedicated path. And this is one that you propose. So this area with the triage is an area in which the personnel should have wear particular PPE in order to be protected. And then we may have a free area, the emergency unit, labor ward, outpatient clinic. And according to this, then the patient will be sent to high-risk pregnancy ward or to the postnatal ward. In this area, in both emergency and labor ward, dedicated ultrasound and the possibility of chest X-ray should be available. Now, what we need is an assisted maternal transport service. This is because, at least as we have experienced in Italy, the pregnant woman with symptoms call usually the general practitioner. And if it's found positive, should contact the reference center. and the transport will be carried out by the team of the peripheral structure to the hospital. Then outpatient clinic, we heard already something about what to do for ultrasound, but the suggestion is to implement telemedicine, of course, to have always a proper dress of midwives or obstetrician if you are in close contact with this kind of patient, and we suggest the ultrasound dedicated for the COVID zone, and of course a triage anytime. Ultrasound fetal monitoring has been already dealt, but if it's not needed, you see the 3 tiers that the ISUOG suggested, and we are of course in keeping with this, the management on antenatal wards. Now, I come back a little bit about steroid use because the suggestion is to use when potential benefit far outweigh the risk. Consider that the high dosage of steroid we use for fetal maturity may aggravate the disease. There are already a couple of reports in Italy that this has happened, so be careful about that. Fetal monitoring only when necessary, weekly multidisciplinary meetings and individualized decision. Chorioamnionitis may, with a fever, may of course trigger delivery, and should take with extreme caution, sometimes may confound the clinical picture. Of course, maternal respiratory deterioration may prompt delivery. And sometimes our anesthesiologists ask us to do a cesarean section early in order to have more space for handling the respiration. And of course, the time and mode of delivery should be individualized and try to shorten hospital stay in normal patients as much as possible. COVID patient may have indication for labor induction just as the normal patient. But for induction of COVID positive, we look at quick induction, usually with a mechanical method followed by oxytocin, as you can see here. Labor ward and delivery, consider obstetric assistant for vaginal deliveries as assistant maneuvers that can produce aerosols. And that is important for that our obstetric unit will be properly dressed. The surgical mask should be taken for patient and allow the removal, as you heard, for pushing, not allow the partner. We don't do this in Italy at the moment. And routine labor management and active management according to maternal condition. According to the suspected chorioamnionitis, we have to consider and to expedite the delivery. There is no contraindication of epidural spinal anesthesia, but continuous fetal monitoring is suggested because it has been described a higher incidence of fetal distress in labor. C-section only on obstetric indication, or if the maternal condition in COVID positive patient is deteriorating, as I just mentioned. And I think that it is nice to withdraw the sample patient from cord blood, placenta, and eventually also nasopharyngeal swab in a newborn is an occasion to look at vertical transmission afterwards. In maternity unit, for the postnatal ward, of course, limited visiting time for the partner, routine postpartum care, avoid the analgesic drugs, no steroids, and the breastfeeding has been already discussed by the FIGO guidelines. These are, for instance, one of the protocols that we use. You see here is summarizing our experience in my region. One of the things that I may not mention, or at least underline, is early clamping of the cord, which is much better. Do not aspirate the newborn with a suction device, no skin to skin, and of course have a neonatologist at birth. This is the one that we agreed with our neonatologists about breastfeeding, and this is a protocol you can find in a FIGO GLOM website platform. And this is the flow chart about a mother which has confirmed positivity to SARS, and newborn can be asymptomatic or symptomatic. So according to symptom or not symptom, we can put the newborn in quarantine, we can detach the newborn from the mother for a while, and then send home later on. Now, what is the second first point is what are the useful information for a pregnant woman. We realize a small video. Don't do a video more than 2-3 minutes, because otherwise women don't follow this. Usually it's too long. We have a video 3 minutes, usually very simple, with very nice cartoons, how to limit the contagion, to record to everybody most important thing is the beginning, and washing hands and so on. Then, of course, some of the evidence that we have at the moment, no viral cross the placenta, or no evidence of fetal malformation, or the invasive perinatal donors, which should be postponed, and we favor the screening tests which are non-invasive. The fact that in labor, the woman can be monitored continuously, and of course, there is no indication for cesarean section. So you see very simple cartoon, and also related to the breastfeeding, and the final is to have this kind of video that we did, and you may prepare very easily nowadays. So key points is that apparently I reconfirm that overall the pregnancy course outcome seems not to be so negatively influenced by COVID-19 infection. No vertical transmission, individualized the management, breastfeeding not contraindicated, neonatal care is a window of transmission, but we have to take some precaution. For reorganizing our maternity, first decide in your region which is the maternity which take care of COVID positive, revise and reorganize the maternal units, have well-trained personnel with a multidisciplinary aspect, all covered, frontline health workers with adequate protection, prepare specific pathways and protocols that you can take from the other but adapted to your need, but always think about multidisciplinary management. I think it is the most important things. And of course, I would like to mention that this platform you are attending today is provided by the Birth Congress, which I and Professor Romero will organize. If everything is going right, end of September, beginning of October in Valencia, Spain, and all of you are invited. And I thank you for your attention and keeping questions, but I think that now I would like to give back the word to our chairman, Professor Fonseca, in order to depict the situation in Brazil, and maybe we take some questions afterwards. Thank you. We can give you the line to Professor Fonseca for his part before the final question turn.
Prof, I think he has some problems with connections.
So we can take some questions.
Yes.
The question I see, I don't know how many have been already answered by Liona and Anil, but the question that I would like to elaborate is the following. There are few protocols for treating pregnant patients with a COVID positive, usually aim to avoid a worsening of the clinical picture in women. One of the protocols is given by the utilization of hydroxychloroquine, which has been found safe for a short period in pregnancy. The only problem with hydroxychloroquine is to do an ECG at the beginning of treatment to avoid a case which may have some problems like QT long, because it's a contraindication. There is not too much evidence instead of the association which has been proposed by others on hydroxychloroquine and azithromycin, because these have not been found only one study is so useful. So if you have to treat your patient for a week with a scaled dose of hydroxychloroquine, 800 milligrams, the first 2 days, 400 milligrams, the subsequent 5 for a week, then you should know that these may clear the virus much faster. okay, and avoid worsening. The second problem is the association, which has mentioned Anil Kapur, with a high dosage of low molecular weight heparin, 8,000 units per day at least. These have been found useful in a severe symptomatic cases, because this is, as you know, pregnancy is favoring per se the thrombosis, and it has been found that in the severe cases, there are much more thromboembolic problems in pregnancy, and therefore I think that in this case it is indicated to give heparin. Although I would say that evidence is a big word for this kind of management of this kind of disease, because we have too limited time. We have very few studies which are being approved and they are ongoing. We need, of course, a number of patients to prove that it's safe, but at least I would say that these two, the use of hydroxychloroquine and use of heparin, seems to be useful in the majority of cases. And this is one way, I think, to answer some of the questions that you have said. Instead, I would be very cautious about the use of corticosteroids, because in some adults, non-pregnant has been found useful, but a very low dosage. And you have to think that the dosage we give for fetal maturity is 24 milligrams in 24 hours. And it's very high doses, and these can be, unfavorable for the progression of the disease. It is not true that most of the labor positive of suspected COVID patients finish in cesarean delivery. We have just recently a normal vaginal 2 days ago of a COVID positive. As I said, sometimes the request of cesarean delivery is in a severely affected patient with pneumonitis, in which anesthesiologists prefer to have a very rapid, let's say, clearance, in this case, of the abdomen in order to better ameliorate the functionality of lungs. Is Professor Fonseca online to continue?
Yes, I'm online. Giancarlo, we have a nice question here, and I think it's important. Could you talk about the performance of the fast M immunoglobulin and G immunoglobulin test? And shall we test every single pregnant woman before put in the hospital when the patient is in the labor ward, if she's symptomatic or asymptomatic? What do you think?
Eduardo, the test, the blood test is telling us only if the patient had or not the disease. The only test which is valid at the moment is the tampon or pharyngeal, and this with a rapid now testing can be performed in 1 hour. Is the only way to detect the positivity of the COVID. So we have to be careful about the two things. I prompt everybody to do this in any patient who is going to deliver, because the time of delivery, particularly vaginal delivery, if we don't protect ourselves well, the biological fluid which are, traveling in the air of the labor ward are, a big challenge for contagion for all attending. And, many people are attending delivery usually, from the midwife to the resident, to the obstetrician, neonatologist, the nurse for the baby, and so on and so on. So I think that in this case, we have at least to test all pregnant patients we are going to deliver. But I urge you to make your presentation, Eduardo, and then to finish with some question if time, okay?
Okay, great. So let me share here. Can you see the presentation?
Yes.
Okay, great. So I'm going to start by data from today from Johns Hopkins Hospital, where we have about 2 million infected people in the world, with deaths about 6.6%. in a total of 3,261 patients tested. So if you go to the Brazilian, so far we have 28,000, nearly 29,000 patients tested, and we have 1,700 deaths, about 1,700 deaths, which is about 6% as well. So, of course, this number might be underestimated because you are not able to test every single patient, and probably the maternal death is lower than this 6% as in the world. But one thing that is very important that we can see here in Brazil, it's something that you saw in US. So in US, most cases, the epicenter came from New York with data from this morning about 200,000 patients positive, and with the death, the mortality rate in about 7%. If you go to Wayne, the area of Detroit that has a similar weather, the rate is about 7%, the death. But if you move on to Miami, so we will have people at the same age of New York and Wayne, but with better weather, the rate of mortality, it's about 1.8%. So it appears to have the rate of mortality and the spread of the virus could be linked to the weather and the density, the numbers of people working in the area. So when you move for the Brazil, and I'm going to bring data from the health minister that was published in 13 of April 2020. Here we had, as you can see in these slides, that the epicenter is São Paulo, with about 9,000 positive cases for 600 deaths. What is about 6%. So in whole country, we have 23,000 positive tests for 1,200 deaths, which is about 6%. So, and when you move for this map, we can see the worst place in Brazil is São Paulo in red, Rio, Bahia, and Recife in the northeast of Brazil, and our capital, Brasilia. So this might be for the influence from people that came abroad in the carnival and spread the disease. So I'm going to bring data from this death is 1,000 deaths, and you can see here in this slide the death is coming out and then down. We have about now 1,066 deaths. And one thing that is very interesting that I would like to point out here, because I would like to bring some new insights that came from Brazil, is the age. Can you see here the age of this group? Most of the death, it's over 60 years, but we have few deaths in young patients. So 74% of the death occur in patients over 60 years old. When you compare the risk, the risk factor linked to the death, you can see that 75%, 3/4, had at least one risk factor, and the most important risk factor are obesity, diabetes, and cardiopathy. And here it's one point that I would like to bring, and we need to discuss much more, Liona, Anil, and Giancarlo. 40% of death was in female patients, and when you go for the COVID in pregnancy, we have this review published in the American Journal. We have 108 cases of patients, pregnant women with COVID. The age of delivery is about 253 days, about 35, 36 weeks. Most were C-section, and there was no maternal mortality. As you can see here in this line, the maternal mortality in all these 1, 2, 3, 4, 5 reports was 0%. We have the maternal unit care unit admission in about 3%. And the neonatal mortality was about 1%, and the vertical transmission that there is doubt was about in 1% in just one study. So with this picture, we can see that there is no risk from this paper for pregnant women when you compare with H1N1 or when you compare SARS and MERS. However, in these new publications from today in the American Journal, Hamsu has demonstrated that in SARS, the largest series with only 12 pregnancies had a case fatality rate of 25%. And the complication was acute respiratory distress syndrome in about 30%, disseminate intravascular coagulopathy in 3%, and renal failure in 3%. And when you go for the Middle East respiratory syndrome, the MERS, so there were 13 cases reports in the pregnant women, of which 2 were asymptomatic, identified as part of contact investigations, and 3 patients of 13 died. So 2 pregnancies ended in fetal demise, and 2 were born preterm. No evidence at that time of utero transmission was seen in SARS and MERS. So the virus is the same. In the past, the maternal death was higher. At this time, we don't have evidence of death in China, in Italy, and in US. The information that we had is there are near miss. So 85% of all patients are asymptomatic or mild symptoms. About 10% it's severe, and 5% is critical and needs to unit intensive care. What you had in Brazil. So in Brazil, as you can see in this picture, and you would like to discuss this, 5 out 1,056 total deaths were during the maternal period, either during the pregnancy or after birth. So 2 cases officially reported by the Minister of Health, plus 3 cases disclosed by the local media coverage. So we had 5 cases of death. 2 cases, the pregnancy, the patient had symptoms during the pregnancy, and both of them were admitted with 32 weeks, and the death was in the postpartum. Both had emergency sections, and there was no comorbidity. So we had 2 cases that the death occurred in the postpartum, 6-7 days of postpartum. So in Brazil, in 1,000 deaths, we had 5 pregnant women or postpartum women. The same we saw in Iran. We had in Iran 2 deaths of 3,800 total deaths in the pregnancy. And the paper was published by Karin and Zarki. And in Mexico, out of 141 total deaths, we had 2 maternal deaths. One pregnancy at 35 weeks, and another one, the symptoms were not reported, but both had postpartum death. The comorbid for the first one was obesity and hypertension, and the second one was obesity and gestational diabetes. What I would like to bring, and I think, Giancarlo, that the big organizations need to reassure that pregnant women are at low risk, or they need to bring attentions and code this patient as a higher risk, at least in low and mid countries, low income countries like Brazil, Iran, and Mexico. I believe the pregnant women is at risk for the infections, because you know that was in the past with H1N1, was the same with SARS and MERS. And here in Brazil is even worse, because at this time, many patients has the assistance that the prenatal care, the difficulties for the prenatal care, and probably we are going to increase the mortality death in Brazil. I think it's time for the ACOG, the Royal College, Praise School, call attentions for pregnant women, at least in low-income countries. We believe our society, our national society, has much more ability for gynecologists, but we need to bring attentions, and we have information from the Society of São Paulo, from the Society of Rio, with good guidelines to have care with this patient. But I believe this is time now that the big universities, I believe that Professor Sugabi is listening us, Rezende from Rio is listening us, that they can bring these discussions, discuss with the health minister, try to do a video conference with
He's lost the voice. Okay, waiting that he's coming back. Oh, yes.
Giancarlo, if I make a comment.
Yes, please.
So
much more about pregnant women.
Okay, he's online. Did you finish, Eduardo?
Yes, I finished. Did you hear the last topic that I bring the attentions for the pregnant women at high risk in the COVID disease?
Is it Anil that want to make a comment?
Well, thank you, Eduardo, for bringing the issue that apparently mortality doesn't seem to be high among pregnant women. But I think it is important for us to look at probably in a retrospective way when things are more settled, because many times these deaths may be ascribed to something else and often may not be ascribed to, there might be other reasons that are ascribed to these deaths, because in terms of statistics and in terms of reporting, there are various issues around the world on this as to how can you ascribe a death to COVID-19. And I think the best way to do that would be to retrospectively analyze what was the kind of maternal mortality in the period 1 year before and during the phase where COVID has been rampant around the world, and only then we would be able to assess this in a better way. The other point I wanted to make is, while there is no specific treatment available for COVID infection, and most of it is supportive care, but we do know that women who might have risk factors with comorbidity are at a much higher risk of poorer outcomes and perhaps even mortality. And it is those things that we can actually address very effectively. And therefore, I would like to plead everyone to ensure that these women are looked for either having hyperglycemia or hypertension, because those are things that we can deal with and correct, and thereby reduce the risk of poorer outcomes. The other is, of course, symptomatic, and which we can't do much about in terms of the active infection.
Yeah, I have a couple of questions that I would like they address probably according to what I mentioned about the possible therapies and of course the organization of a maternity unit. I would like to emphasize again that hydroxychloroquine has been found to be completely safe by recent meta-analysis. And this has allowed at least many to do the treatment only with hydroxychloroquine, not with the association with azithromycin, but only hydroxychloroquine for only 7 days. This is the maximum, and you can use for 2 days at 800 milligrams and 5 days of 400 milligrams, okay? And this has been found without no effects in pregnancy. Now, there are questions related to the mortality. Of course, mortality rate is depending from the denominator. And if you underestimate the denominator, you do higher mortality rate. And it depends from also the population you are testing, because you don't know how much is the population you are testing. Most probably, we have a lot of women which have COVID positive asymptomatic pregnancy, which are completely, not entering in the statistics. Therefore, what we can do. Concerning other treatment or the rates of autonomy postpartum, there is no data, but apparently the biggest statistic presented by the Chinese don't show any increase of postpartum hemorrhage. And about operative labor or cesarean section, I think that the indication should be mainly, except for what I said, mainly based on fetal maternal indication without considering the COVID. So I think that more or less we have tried to address many of the questions which have been raised. The only question which I think is sent to Liona, but I don't know if Liona is online, is why you discourage the use of tocolytics. Apparently, I would say that if we decide not to give corticosteroid, I don't think that we have to need a tocolytic. We have also to think that our neonatologists are very good to save babies preterm with the surfactant. But I would like to have Liona to mention a little bit about this question, why you suggest that tocolysis should not be used, or at least avoided.
I think the key is that if you are dealing with a critically ill patient with spontaneous preterm birth, then in context, if we are, as Professor Renzo has mentioned, if we are not considering prophylactic steroids, then I don't see the purpose of tocolysis.
Right.
Because obviously there could be chorioamnionitis in relation to her disease process, and by prolonging her pregnancy could worsen her clinical course of COVID-19. So here we're not discouraging, but we are saying caution. And I think in the case when you are not considering steroids, then you should not consider tocolysis.
I'm in agreement with this view.
Giancarlo, we have a very nice question here about skin-to-skin contact with mom and babies after delivery. How long do you separate moms and baby for? So Mary Doughton brought a very nice paper in the New England Journal, where she checked for COVID in about 200 patients. So, and in this asymptomatic group, about 14% was positive, and in about 88% of COVID positive, there was no symptoms. So with these numbers, do you think that you should avoid skin-to-skin contact now? And if you avoid, for how long we should separate baby and mom? Taking account this data from Mary Doughton, that about 14–15% of all pregnant women that came for the labor ward was positive.
I'm aware of this New England Journal paper, and in fact, this is urging more the need to screen all patients before delivery. That is the point. It's not the point after. If you don't know, of course, and the patient is asymptomatic, and you presume that he is negative, why to avoid a normal delivery with the skin to skin and breastfeeding? There is no reason. But unfortunately, we know that according to the place, because let's say that United States, according to the peak, you may have 13 or 10% of patients that may be positive asymptomatic. But then the peak is going down. You may have much less number of positive asymptomatic patients, also because positivity is going down. So I don't think that we have to, make a statement that we have, to base our skin to skin on the risk that the patient can be COVID positive. I think we have to screen the patient, and if they are found positive, then we separate for a while and we check until the patient is negative. When the patient became negative, then she will be rejoined with the baby. And in the meantime, she will express the milk, and the milk will be given by expression. When the patient is instead positive but without symptoms, then she has to protect very well, but she can breastfeed somehow. But she has to clean the hands and so on. There is also a suggestion from some people not to wash and to clean the baby for the first 24 hours, to leave the vernix caseosa to remain in the body of the baby, because the vernix is antibacterial and apparently may protect from, the contagion. I don't know how much is true, but it has been described as well. So we have a lot of creativity, a lot of evidence, a lot of good sense, I would say. But please, you have now seen the FIGO guidelines, the ISUOG guidelines. You can go in the platform of FIGO to download everything, but for free, for ISUOG as well. So please follow these guidelines, because there is at least a consensus of a group of experts, and I think that this is what we have to follow. Of course, adapt to your situation.
Giancarlo, just I'd like to make clear for the Brazilian doctors, and I would like to push the health minister for that. So you believe that every single pregnant woman in the labor ward should be tested for COVID by PCR, and then we are going to follow this patient according to the test, positive or negative?
This is my suggestion, yeah.
Excellent.
Yeah. This, I think, I don't know, Liona, you think the same?
So come again?
Liona, taking account the Mary Doughton paper that showed that 14% of patients was positive.
Yes.
Do you think that you should test every single pregnant woman that is in the labor ward before delivery?
I think that's
should be routine.
It's a very, very interesting question, and this is certainly a discussion with public health specialists. In Hong Kong, this has not been done because we have flattened our curve, and therefore our chance of positivity based on universal screening will be very, very low. But in the context whereby you have widespread community spread of the infection, then this should be considered. And of course, how do you define that level of transmission in your community? And this is to be discussed with your public health specialist. And I don't think it is really up to me to tell you must test everybody, and you have to really balance the pros and cons, and also to ensure that it's appropriate, you will achieve appropriate screen positivity. If you're looking for 0.1% screen positivity, then there's probably, you need to reserve your energy on something else. You know what I mean? But of course, in New York, it's a no-brainer that they need to provide universal screening, and in Italy, it was necessary, and so I think depends on your expectation.
I'd like to add to this discussion. If you look at the data from the US, 1 out of every 6 person tested has been found positive. And so if that is the rate of transmission, obviously you need to test pregnant women because they are also likely to be. But in many other countries where the rate of transmission is not that high, as Liona said, it is not necessary to test every woman.
I would like just to highlight that the maternal death in Brazil, 3 out of 5 was in postpartum, 2 in day 6 and day 7, and the patient was completely asymptomatic during the labor and the delivery. So this is one thing that we think about, Giancarlo, and I think you are right. We need to think to check this patient, at least here, where the maternal mortality seems to be higher in this group.
I don't know if we have any other important question. I see that there are some comments which are very, very good, of course. Some say that they do screening when any patient enter in the labor ward, and is okay. Also the fact in the postpartum period, but you know, if we dismiss the patient usually after 2 days, then it's a matter of the domiciliary attention to this patient afterwards, because we cannot take the patient for longer if they are completely asymptomatic and the delivery was normal. We dismiss a maximum 3 days also cesarean section. I understand that breastfeeding is important, but we don't say that the baby should not be breastfed. He received the milk from the mother because there is no evidence of a transmission of the virus through the milk. But the transmission can be with, of course, with the fluge, with the breathing of the mother, if it's not protected enough. And the protection should be very good. And finally, I think that if the baby needs to be intubated, this is the same as we do in the same precaution we need for the adult. The material should be dedicated, should be clean, and of course, because in this case, the baby may need, you know, intubation for other reasons. I don't know which else are the important questions, because I think also Liona has answered many of them in general with the presentation. I don't know if you want to do a final comment, Eduardo, because I think that we are on time for closing the webinar.
Oh, I'd like to thank you, Giancarlo. I think it's time to discuss about COVID, but we need to think in COVID as we need to at least take good things from this pandemic time. And I think one good thing is this possibility to have this discussion now with COVID, but later on with diabetes, gestational diabetes, hypertension, is screening for preeclampsia, and allow Brazilian doctors to share experience and to learn much more from Liona, from Anil, from you. So I think one good thing that you could take from this COVID-19 is from now to start this kind of discussions free and open the possibility for every single doctor in Brazil and from abroad can take knowledge and can discuss about their practice. So my last words is just thank you, Giancarlo. Thank you, Liona. Thank you, Anil. We connect the world for just one thing: maternal health. This is good.
Thank you, Eduardo. And obviously a brief reminder that the presented guidelines from FIGO and various consensus documents from ISUOG. They are freely available. So please go to the website and you can learn more. Thank you very much.
I'd like to also say thank you to the organizers and to all the participants, and to say, isn't it funny that we are all meeting from Hong Kong to Brazil at the same time to talk about this pandemic, and it is really amazing what can be done with the new technology. So thank you, Liona, in particular you for working on these guidelines with FIGO and ISUOG, and doing it in such a timely manner that we have something worthwhile to follow everywhere in the world.
And remind that this infection has tell us that we don't have any recipe that is evidence-based, so we have to be very flexible in changing mind, in trying to do our best for the sake of our women and babies. And it is very important to keep attention, to minimize our intervention, to use only what is feasible, but also to protect ourselves. Because unfortunately, I would say in Italy, we are crying more than 120 doctors who died in taking care of patients with the COVID. So this is the other side of the medal, or other side of the moon. Protecting the woman and making the best should also mean protect the doctors and to avoid contagion in the labor ward and during delivery and after delivery. Okay, this is a message that we have to keep in mind.
Thank you. So I think we can finish now, and let's review each questions, and then you can answer later on for each the participant. Thank you.